Hello, welcome back to Know the Heart of ICU, cardiac in service education programs offered by the Intensive Care Department in Letterkenny University Hospital. In the Unit 1 Dysrhythmia, we had seen the Chapter 1, that's a normal ECG, and today we are going to see Chapter 2, which is all about all abnormal rhythms. Today's learning outcomes are, at the end of the session, you should be able to detect abnormal rhythms. You should be able to distinguish between sinus, atrial, junctional, and ventricular dysrhythmia, and you should be able to explain the characteristics of each abnormal rhythm. When it comes to dysrhythmia, everyone knows many abnormal rhythms, but it is important to organize based on the source. Then it's easy to remember. The impulse, the cardiac impulse, is generated which part of the heart? That is a crucial question. Where is it generated? Where this abnormal rhythm comes from? Based on that, we can divide the rhythms into the abnormal rhythms into four: sinus, atrial, junctional, and ventricular. The sinus dysrhythmia originates from the SA node. That's if an impulse originates from the SA node and it's abnormal, it's not normal. For example, if it's a sinus brady or a sinus tachycardia, the impulse originated from SA node, but still it's not normal. It's slow or tachy. So that is called as sinus dysrhythmia. And if the impulse is originated from elsewhere in the atria, that's called as your atrial dysrhythmia. If the impulse originates from junction or AV node, it's called as your junctional dysrhythmia. And if the impulse originated from anywhere in the ventricle, that's your ventricular dysrhythmia. But how will you know where the impulse originated from? When you see a QRS complex or when you see a P wave, how do you know? Is it from SA node or is it from atria? Is it from junction or is it from ventricle? It's easy. One thing, if it's ventricle, it's very easy to identify any ventricular complex, any QRS complex originated, actually the impulse originated from the ventricle, the QRS will be wide and bizarre. So it's easy to understand. But all the supraventricular complexes, that is, if the impulse originates from SA node or atria or junctional, it's hard to understand, hard to distinguish, because every QRS will be narrow. So if the impulse originates from the ventricle, easy to identify, it will be broad and bizarre. So we'll go in detail. How will you distinguish a sinus impulse? It's easy to distinguish a sinus impulse because we see it most often. A sinus impulse means impulse is originated from the SA node, sinoatrial node. Impulse is originated from the SA node and it is transmitted to the interatrial bundle to the atria and internodal bundle to the AV node. And once it reaches AV node, it passes down normally. So the impulse to the ventricle is mediated through AV node. It produces a narrow QRS complex. So you have a nice and smooth P wave, and most of the P waves will be upright except in lead AVR. If all the P waves are upright except in lead AVR, and if it's nice and smooth, definitely that is from your SA node. So, and it will always have a narrow QRS complex, because any ventricular QRS complex from an impulse which is mediated through AV node, that will be narrow. The only QRS complex that is the impulse not mediated through AV node is your ventricular complex, because that is produced below the AV node. So it's produced within the ventricle, so there is no AV node involved. That's why it has a bizarre shape. But all the supraventricular impulses, that is from impulse from SA node, impulse from AV node, impulse from atria, are actually passing through or mediated by the AV node. So the impulse will be, the ventricular complex will be, QRS will be nice and narrow. The normal QRS will be. So if you want to know, is it an SA node impulse, you look at the P wave. P wave will be nice and smooth, and P wave will be inverted only in your AVR. And how will you know an atrial rhythm or an atrial impulse? How will you identify, oh, this abnormal impulse is coming from an atria? Usually an atrial impulse will have an abnormal P wave. It will have a P wave and it will have an abnormal P wave. Based on which atria the impulse originates, it can have an abnormal pattern. So it can have inverted P wave in multiple leads. So if it's an abnormally shaped P wave, yes, it's an atrial. And if it has different, you can have inverted P waves in multiple leads, yes, that's an atrial complex. And if there is no P wave, for example, in atrial fibrillation, there is no P wave. There is no discernible P wave. That's called your atrial impulse. So you can easily identify the atrial impulse, and you can distinguish between SA node impulse and atrial impulse, because SA node P waves will be nice and smooth, and SA node P waves are usually inverted only in lead AVR. But impulses originated from elsewhere from atria will have a rough shape. It can be varying shape, but it won't be nice and smooth. And sometimes there may not be any P wave at all, just in case of an AFib. And you can have inverted P wave in multiple leads. And the QRS complex, no matter where the impulse is produced, if its impulse is passing to the ventricle through the AV node, impulse will be normal, the QRS will be normal, narrow complex. So here the impulse is produced in atria and it is passing through the AV node, so the QRS is narrow. Then how will you know a junctional impulse? If the impulse is not produced in atria or SA node, and if the impulse is produced in the AV node, that's called as your junctional complexes or junctional rhythm or junctional impulse. And how will you know? Your P wave may be absent. If it is present, it may be inverted, and it will be inverted, and it may be before QRS or after QRS. Looks slightly complicated, right? Just to look at the AV node. AV node has three different zones. You know the place of the AV node, the position of the AV node. AV node has three different zones: the high region, mid region, and low region, or high nodal, mid nodal, and low nodal. If impulse originates from the high region, what happens? It is closer to the upper portion of the AV node, is closer to atria than the ventricle. So impulse reaches the atria before it reaches the ventricle, because the upper part of the AV node closer to the atria. But usually atrial impulse is originating from atria or SA node, impulse moving from up to down. So you have a P wave that's upright. But this is just reverse. Impulse moving from down to the upward direction. So from here to up. So what happens? AV node will be opposite direction. That means your P wave will be opposite direction. So when it comes to the high nodal rhythm, you have an inverted P wave, because instead of from SA node or atria, impulse traveling from high area to the higher part of the heart to the lower part of the heart, instead of that downward direction, here the impulse is moving upward direction from the AV node to the atria. So impulse is moving upward direction rather than downward direction. So you have an inverted P wave. And just because it's the upper part of the AV node, which is closer to the atria than the ventricle, the P wave will be, the inverted P wave will be just before the QRS complex, because impulse reaches the atria first, then the ventricle, because it is the area of the AV node that is closer to the atria, that's a high area, upper area is producing the impulse. So impulse reaches the atria first, then the ventricle. So you have an inverted P wave just before the QRS complex. What happens if the impulse is originating from the mid zone of the AV node? Impulse reaches atria and the ventricle at the same time. You know that the P wave is very tiny and the ventricular complex, QRS, is big. So what happens? P wave will be merged with the QRS and you will not see any P wave if the impulse originates from the midway of the middle portion of the AV node. That's called as mid-nodal rhythm. And if the P wave is impulse is originated in the lower area of the AV node, that's called as low nodal rhythm. What happens? Lower part of the AV node is closer to ventricle than the atria. So the impulse reaches the ventricle first and then it reaches the atria. Still, the atrial impulse is going in a upward direction rather than downward direction, as if in a normal ECG. So what happens? When it goes to the opposite direction, P wave will be inverted, but it is happening after the ventricular contraction or after the ventricular depolarization. So you can have a inverted P wave in the after the QRS complex. So the high nodal area, that is the upper portion of the AV node, closer to closer to the atria than the ventricle. So if the impulse originates from the upper portion of the AV node, there will be an inverted P wave before the QRS complex. And if it is a mid-nodal zone, impulse reaches the atria and ventricle at the same time, so the P wave is too tiny when compared to the QRS complex, so you won't see a P wave. There will not be any P wave. You will have only a narrow QRS complex. And if the lower zone of the AV node produces the impulse reaches atria and ventricle. It is closer to the ventricle, so impulse reaches the ventricle first, so it produces a QRS complex. Then it reaches the atria, so it produces an inverted P wave after the QRS complex. So you can have three options: either no P wave, or an inverted P wave before QRS, or an inverted P wave after QRS. But the QRS complex will be narrow. Here is a comparison of three kinds of junctional ectopics, or three kinds of junctional waves. See the P wave, if it's from the high nodal area, the P wave will be inverted and before QRS. If it's a mid nodal area, there won't be any P wave. If it's a low nodal area, P wave will be after QRS complex. Inverted P wave will be after QRS complex. So if you want to recognize a junctional rhythm, look for the P wave. If there is no P wave, and if it's regular, if it's not AFib, definitely it will be junctional. If there is an inverted P wave before or after QRS and it's regular, it's definitely a junctional rhythm. Okay, this is how we identify junctional rhythm. So we know how to identify SA node impulse, smooth P wave and inverted P wave only in the lead AVR. And if it's how to distinguish, differentiate between the SA node and SA node and atrial rhythms. In the atrial, P wave is dodgy shaped. It will be kind of awkward shaped, and you can have inverted P waves in multiple leads. And junctional rhythm, based on the area of the AV node producing the impulse, there may be inverted P wave before QRS or after QRS, or sometimes there may not be any P wave at all. And the ventricular beats, ventricular origin, the impulse of waves of ventricular origin, easy to understand. Your PVC is a ventricular origin, wide, bizarre QRS complex, and there won't be any P wave for that particular ventricular beats. So all these waves are normal sinus, and you have a ventricular beat. So the impulse for this beat is not from SA node, because there is no smooth P wave. It's not from atria, there is no P wave. It's not from junction, because it's wide and bizarre. Junctional complex will be narrow, so it is definitely a ventricular complex. So this is how we know and we distinguish between an atrial impulse, SA nodal impulse, junctional impulse, and a ventricular impulse. And when it comes to the when you come to summarize that, sinus node is the impulse from SA node. It will be smooth P wave and narrow QRS. Atrial, abnormally shaped P wave or no P wave in AFib and narrow QRS. And junctional, there will be inverted P wave before or after QRS, or if it's a mid-nodal rhythm, no P wave, and the QRS will be narrow. Ventricular, easy to blind pick, it will be broad, bizarre QRS and without any P wave. And when it comes to the dysrhythmias, you can, as I said before, you can classify the dysrhythmia based on the origin of the impulse. If the impulse is originated from, abnormal impulse is originated from the SA node, it's called as a sinus dysrhythmia. If it's from the atria, it's atrial dysrhythmia. From the junction, from the AV node, it's junctional dysrhythmia. And if it is from the ventricle, it's ventricular dysrhythmia. So there are three atrial dysrhythmia. One is sinus brady, you know that. The SA node is slower in producing impulse. So once the impulse is produced, everything working fantastic, everything working normally, but it's a bit slower in producing impulses. So you can see here the P wave, SA node fires, and there is a P wave, and you have a PR interval and reaches AV node, narrow QRS complex, and a T wave, but the next SA node firing is delayed. But once it is fired, it follows a normal path, but the delay in the SA node firing. So it's called a sinus bradycardia. So it's a delayed SA node firing. That's your sinus bradycardia. The rate will be less than 60. And tachycardia, just opposite of that. Faster SA node impulses. The rest everything is normal. You can see here nice and smooth P wave and the PR interval, QRS complex, T wave. Then SA node fires very quickly. So there is the TP interval, the interval between the end of P wave and the beginning of end of T wave and beginning of P wave is very short because SA node is quickly firing, rapid firing of SA node. So the rate will be more than 100. That's your sinus tachycardia. Usually sinus tachycardia, we won't call anything as sinus tachycardia if the rate goes above 140, just because we cannot recognize from a strip, because if it is more than 140, usually the P wave will not be visible. So we simply classify it as a supraventricular tachycardia. Okay, so you have two abnormal sinus rhythms now, sinus brady and sinus tachy, and one more. What happens if the bradycardia and tachycardia comes alternatingly? Sinus arrhythmia. If the rhythm is irregular, the SA node still it's fired by SA node, but SA node is following a rhythm. It's just go irregular. Irregular SA node firing. It's not a brady firing. It's not a tachy firing. It's a irregular SA node firing. That's called as your sinus arrhythmia. Most of the athletes or young people usually have a sinus arrhythmia. That's called a physiological sinus arrhythmia. But sometimes it can be critical. That means it can go very brady and very tachy, called as tachybrady syndrome. It can go really low to 40s and 30s, and the next moment it can go your hundreds. So it's fluctuating between sinus brady and sinus tachy. That's called as tachybrady syndrome. That's a dangerous condition. But for youngsters, there is slight variation in the rate, especially with the breathing. It's quite normal. On inspiration and expiration, there may be slight difference in the rate. So sinus arrhythmia can be a normal thing in healthy young individuals and athletes. And even sinus brady may be normal in athletes. If you do heavy workouts, that's quite normal. But tachybrady syndrome is definitely abnormal, so that needs a cardiology opinion. So now you know 3 abnormal rhythms from SA node. That's all from SA node. Okay, sinus tachy, sinus brady, and your sinus arrhythmia. So 3 dysarrhythmia from SA node. There are other dysarrhythmias, sinus exit block, sinus arrest, but don't look into that. It's not that important, so just leave it behind. Okay, the next area of dysarrhythmia is your atrial dysarrhythmia. So there are 3 dysarrhythmia from the sinus node: sinus brady, sinus tachy, sinus arrhythmia or tachybrady syndrome. And you have another one, if the impulse originates from atria, that's atrial dysarrhythmia. Atrial dysarrhythmia can happen in many forms. The first one, the most common one, is your premature atrial contraction. It's a harmless one, doesn't cause much problems. Premature atrial contraction, it's easy to understand. In a normal sinus rhythm, in a strip of normal sinus rhythm, before the normal SA node impulse originates, if an impulse is produced by an atria, that's called as a premature impulse, because the impulse is originated, impulse is fired prematurely. Before the next normal beat, impulse is fired prematurely. That's why it's called as a premature. And this impulse is fired from atria. That's why it's called as premature atrial complex or premature atrial contraction. So you can see here a P wave, SA node P wave, QRST, and SA node P wave, QRST, and SA node P wave, QRST, SA node P wave, QRST, and the next SA node P wave supposed to be here, but before the next SA node P wave, some part of the atria, a naughty area, just fired a premature impulse. How would you know that it's atrial? You can see the shape of the P wave. There is P wave and it's upright, so definitely atria, not junctional, not ventricular, because complex is narrow, not wide, so it's not ventricular. The P wave is upright, so it's not junctional. So it's definitely, and the P wave is not normal, so it's not atrial, it's not SA node 2. So you can see the difference in morphology of P wave. So this premature complex is originated from atria. That's why it's called as a premature atrial complex. So there's a premature complex fired by some part of atria. Then AV node is conducted to AV node. So there is a PR interval. And once it reaches AV node, AV node doesn't know is it from SA node or any other part of the atria. So it's transmitted down to ventricles. So you have your narrow QRS complex. But at this point, SA node supposed to fire a complex, because before the normal SA node firing, here there is a premature firing from some part of the atria. But what SA node does, it will just stay quiet. Because there is already an electrical activity going on in the heart, the SA node will stay quiet and it fires on the next rhythm. So it just follows rhythm and it misses a beat and it just gets into the next rhythm. So next beat. So what happens? There will be a bit longer RR interval to compensate a shorter RR interval happened with the premature complex. This is called as your compensatory pause. So this is a classic symptom in a classic sign of a premature atrial complex. There will be a shorter RR interval and a compensatory pause, or a longer RR interval followed by. Recently in our ICU we had a confusion, like there was an irregular rhythm and there were P waves. So people initially thought it's a PAC, but definitely it was not PAC, because PACs classically it will have a shorter RR interval and a longer RR interval after. So that's called as a compensatory pause. That's a classical symptom of PAC. So if there is nothing like that, it may be a multifocal arrhythmia or atrial arrhythmia, or it may be a sinus arrhythmia. Okay, so here, this is a premature complex. Just because there is an upright P wave and abnormal P wave, it's not from sinus, not from junction, not from ventricle, so it's from some other part of the atria. So it's a premature atrial complex, and the classical sign is your shorter RR interval followed by a longer RR interval. And the next abnormal rhythm from atria is atrial tachycardia. Some part of the atria can fire rapidly, maybe more rapid, faster than the SA node. What happens? SA node will keep mum. Whenever any part of the heart fires at higher rate, the rest of the heart stays silent. That's a normal rule in the heart. So when a part of the atria fires faster than SA node will stay silent. If a part of the junction, as AV node, fires faster than SA node will stay silent. If a ventricle fires faster than SA node will stay silent. So you will end up in a ventricular tachycardia. So here, if the impulse is originated from atria and it is firing faster than SA node, so SA node is silent, the resultant rhythm is from atria. So how will you know it's an atrial rhythm? You know that there will be abnormal P wave, there will be inverted P waves in multiple leads, and there will be a narrow QRS complex. And there can be two ways the atrial tachycardia can occur. It may be multifocal atrial tachycardia. In that case, what happens? The P waves will be different morphology, because if it's from different point of origin, there will be different morphology. Different fathers, different types of sons. In the same way, if the impulse originated from left atria is different from right atria, different from upper part of the atria is different from the lower part of the atria. So if the impulse is originated from multiple parts of the atria, there may be irregular waves and there may be different shape morphology P waves, and that's called as multifocal atrial tachycardia, or MAT. Or if it's a regular single focal or a unifocal atrial tachycardia and it's regular, that's called as your paroxysmal atrial tachycardia, or PAT it's called as. Or simply, if it's not paroxysmal, it's an atrial tachycardia. So you have a MAT and PAT, multifocal atrial tachycardia and paroxysmal atrial tachycardia. So the P waves will be different morphology. Every P wave is different morphology, then it's a MAT. And if it's a P waves are different from normal but follows the same pattern, it's a paroxysmal atrial tachycardia. That's your atrial tachycardia. And the third rhythm, third atrial dysrhythmia, you know that, atrial flutter. Sawtooth P wave. It can be that's a classical symptom everyone knows from ICU, definitely everyone knows. Sawtooth P wave, and it can be fixed and regular. That means after every 3 P waves, a QRS complex. It's fixed and regular, 3:1. Or it can be 2:1. Or it can be 5:1. Or sometimes it can be varying conduction. So atrial flutter, 3:1 flutter, 2:1 flutter, 4:1 flutter, or flutter of varying conduction. That's how we classify that. Now, why all the atrial complexes are not conducted down to the ventricle by AV node? AV node has a physiological block function to prevent ventricular tachycardia. For example, in atrial flutter, atria is firing more than 150 times a minute. But if AV node conducts all these impulses down to the ventricle, what happens? Ventricle will end up in ventricular tachycardia. To prevent that, the body has a function, so it's a safety valve kind of thing. AV node filters the atrial impulses and it conducts only every third one or every second one, or it doesn't follow rhythm, it just randomly send one down. So that's why the atrial rate is different from your ventricular rate in atrial flutter. So atrial flutter, sawtooth P wave, classical symptom, and it's a part of supraventricular tachycardia and a precursor for AFib as well. And atrial fibrillation, there is no proper wave, there is no discernible P wave, just kind of twitching movement in the atria. So you have just kind of a little little shakes in the wave. That's it, no formal proper wave in the P. But that means just because atria is firing, some parts of the atria is firing more than 300 beats per minute. That's why you cannot see a wave, rather it's just kind of shivering or twitching movement. So what happens? All these 300 beats, all these 300 impulses per minute, or more than 300 impulses per minute in an atria will not be conducted down to the ventricle by the AV node. As I said before, there is a therapeutic block, there is a physiological block to prevent the ventricular fibrillation. So what happens? The AV node screens and randomly send one down to prevent ventricular tachycardia and ventricular fibrillation. So you have an irregular QRS complexes. Just because it is passing through the AV node, the QRS complex will be, whatever be the QRS complex, it will be narrow, but it will be irregular and there is no discernible P wave. That's the classification, or that's the criteria for your atrial fibrillation. So no discernible P wave, rate will be irregular, and it's a part of supraventricular tachycardia. Okay, then that's all the atrial tachycardia. So atrial tachycardia, you have premature atrial complex, your atrial tachycardia, your atrial flutter, and your atrial fibrillation. In sinus dysrhythmia, you have your sinus brady, sinus tachy, and sinus arrhythmia, including tachybrady syndrome. In atrial, you have your premature atrial complex or PAC, and you have your atrial tachycardia, atrial flutter, and atrial fibrillation. So you have covered more than half of the dysrhythmias now, and you can recognize more than half of the dysrhythmia in the clinical practice. And the next one is junctional dysrhythmias. As the name stands for, the junctional dysrhythmia originates from the AV node. Just like your premature complex, if the premature complex originates from the some part of the atria, there will be upright P wave, so we call it as a premature atrial complex. But what happens if the premature complex comes from the AV node? That means an inverted P wave before the QRS, or inverted P wave after the QRS, or no P wave at all. That's called as a premature junctional complex. Let's see this one. See, you can see here the P wave. So SA node fires, left atria, right atria, your PR interval, and you have your it reaches AV node, passes down to the ventricle, so you have your QRS complex. So normal rhythm, normal rhythm, normal rhythm, normal rhythm, and the next normal P wave supposed to be here. Next normal P wave, see the interval, next normal P wave supposed to be here. Before the normal P wave, some part of the heart fired an impulse. We don't know, is it from atria, we don't know, is it from junction, we don't know, is it from ventricle. But that QRS complex is narrow, so ventricle is out of question. It's not from ventricle, because ventricular complex is bizarre and wide. So only two questions remains: is this premature complex from atria or junction? If it's from atria, there will be a upright P wave. Is there any upright P wave? No, the P wave is inverted P wave. It's maybe, we may think it's a Q wave, but see, no Q wave in other parts, other QRS complexes. So this one is a P wave, not a Q wave. So you have an inverted P wave before the QRS complex, and the QRS complex is narrow, so it's a junctional ectopic. So it's a premature junctional complex. If you want to diagnose very precisely, it's a high nodal premature junctional complex, but we just go for PJC, or premature junctional complex. So it's a premature impulse, and it is from junction because it's an inverted P wave just before the QRS complex, not an uprighted P wave. So it's a premature junctional complex. And sometimes SA node will be completely silent. Your atria not producing any impulse. So what happens? We will go to asystole. To prevent that, AV node start to produce an impulse. The AV node rate is somewhere around 40 to 60. So it can produce impulse at a rate of somewhere in between 40 to 60. So what happens? You have a slow rhythm, a bradycardia of junctional origin. How will you know that it's a sinus brady or a junctional brady or a junctional rhythm? How will you know that? See, look at the P wave. The P waves are inverted before the QRS complex, or there may not be any P wave, just a narrow QRS complex and T wave, or the P wave may be after narrow QRS complex. That means it's a junctional. So it's a junctional rhythm. If the junctional rhythm acquires a rate of sinus node, that means if a junctional rhythm acquires a rate of more than 60, we call it as an accelerated junctional rhythm because normal junctional rate is below 60. So if it's a normal rate, it's an accelerated junctional rhythm. But just go with the junctional rhythm. So it's a junctional rhythm just because this QRS complex is originated from junction. There is no impulse from SA node, no impulse from AV node because there is no upright P wave. All the P waves are inverted P waves and narrow QRS complex. So it's definitely from junction. It's not from AV node. If it's not from SA node, it's not from atria, it's not from ventricle. It's definitely from junction. So it's a junctional rhythm. And what happens if the junctional rhythm goes tachy? More than 100. That's called as a junctional tachycardia. There are two kinds of junctional tachycardia. Broadly, we call it as SVT, but there are two kinds of junctional tachycardia. One is actual junctional tachycardia and second one is AV and RT. Both look same, only the physiology of production is different. In a junctional tachy, AV node producing impulses at a faster rate, and AV and RT, AV node producing impulses at a normal rate, but there is a re-entry phenomena happening within the AV node that is produced. The re-entry phenomena is responsible for the tachycardia. But don't think about all that. Just go with the junctional tachy or AV and RT. That's a junctional tachycardia. That means if you see a P wave, there will be narrow complex tachycardia and it will be regular. And if there is a P wave may be a P wave definitely inverted, maybe after or before QRS complex, but it will be definitely inverted. So that's the classical sign of a junctional tachy. So you will straight away you will know it's not a sinus rhythm. If it's sinus tachy, there will be P wave upright. If it's an atrial tachy, there will be P wave upright. And if it is junctional tachy, there won't be any P wave. If there is P wave, it will be inverted before or after P wave, after QRS. And it's definitely not ventricular because ventricular beats will be wide and bisect. So it's blind pick. It's definitely, we can go 100% sure it's a junctional rhythm. But if it's very tachy, like very fast rhythm, how will you know? Is it from atrial tachy or it's a junctional tachy or a sinus tachy? Two ways. One way we can do it on the monitor using physics. You can just increase the time span of the ECG to 50 mm. So what happens is 25 mm per second, instead of 25 mm per second, you can just extend into 50 mm per second on our monitor. So you can stretch the ECG waves so you can see is there any P wave. Or clinically, if you want to prove that if you want to distinguish between junctional and atrial tachycardia, you have to give adenosine and record your ECG. So when the adenosine is given, your AV nodes are blocked, so your ECG will be slowed down, but you can see your P waves clearly if there is a atrial tachycardia. So you can distinguish with the adenosine. So the rate will be more than 100, and it's a part of supraventricular tachycardia. And if there is P wave, it will be inverted, and it may be before or after QRS complex. That's the criteria for your junctional tachy. These are the three junctional abnormal rhythms: premature junctional complex, your junctional rhythm, and junctional tachy or AV and RT. So the next one is ventricular dysrhythmia. You're done. You're finished. You can blindly pick the ventricular dysrhythmia. You know the premature ventricular complex? Wide bizarre complex in between a normal rhythm. That's your premature ventricular complex. And it may be from the same source. If it is from the same source, all the complexes are the same shape. See the shape here? This is different from this. That means it's from the different sources, different parts of the ventricle producing, responsible for these QRS complexes. So we can call it as a multifocal or polymorphic. Two terminologies. Both are correct. Polymorphic means different morphology. Multifocal means different source of origin or different source of impulse. Impulse is definitely from ventricle, but if one is from right ventricle, one is from left ventricle. So that's why the one is upward, one is downward. So different parts of the ventricle is firing. So it's a polymorphic PVC or monomorphic PVC or multifocal PVC or monofocal unifocal PVC. Okay, anyway. When it comes to the ventricular rhythm or idioventricular rhythm, the ventricle can, like the junctional rhythm, if the SA node is not firing, your atria is not firing, and your AV node is not firing, still you will not end up in your asystole. Your ventricle will start to fire. That's called as an agonal rhythm, or that's called as a ventricular rhythm or idioventricular rhythm. The rate is very low. Ventricle has a lower rate. The normal ventricular rate is around 20 to 40. So if that happens, we call it as a ventricular escape rhythm, or we call it as a ventricular rhythm, or we can call it as a idioventricular rhythm. And if the ventricular rhythm, we know that it's ventricle, no P wave, why it be say QRS complex, definitely it is ventricular rhythm. And if it follows a normal rate, if it is in a more than 40 or more than 60, we call it as an accelerated ventricular rhythm. If it is tachycardia, we call it as your ventricular tachycardia. So you have learned your PVCs, polymorphic, monomorphic PVCs you learned, and you learned your idioventricular rhythm, and you learned your ventricular tachycardia. You know that the ventricular tachycardia, wide Bisser QRS complex, and its tachycardia more than 100 rate. It can be polymorphic, or it can be monomorphic. It can be of different morphology, then it's more dangerous, and it can be monomorphic, or it can be multifocal or a single focal. When your patient has ventricular tachycardia, first thing you have to do, you have to check the pulse. And if there is no pulse, it's a cardiac arrest, and you have to shock. These are the major three rhythms, and the last one is your ventricular fibrillation. Two shockable rhythms, ventricular tachy and ventricular fibrillation. No waves at all, just no discernible wave, just kind of a fibrillatory waves or fibrillation, kind of just a twitching movement. There is no discernible waves, no P wave, no QRS, no T, and just kind of a shivering. Cardiac arrest, shock. No pulse, shock. Okay, so these are your dysrhythmias. So when you concise based on the origin, you can classify the dysrhythmia. How will you know the origin? For sinus, smooth P wave. Atrial, abnormally shaped P wave. Junctional, inverted P wave before or after QRS, or no P wave at all, but a narrow QRS complex. Sinus, atrial and junctional will have a narrow QRS complex, and ventricular, wide Bisser QRS complex, easy to know. And based on these origins, we can classify the dysrhythmias into four. If the dysrhythmia originated from sinus, it's sinus arrhythmia or sinus dysrhythmia. It is maybe sinus brady, sinus tachy, or sinus arrhythmia. If the dysrhythmia originated from atria, it may be premature atrial complex, atrial tachycardia, atrial flutter, atrial fibrillation. If from junctional, premature junctional complex, junctional rhythm, junctional tachy, or AV and RT. If from ventricle, PVC, premature ventricular complex, ventricular rhythm, ventricular tachycardia, or ventricular fibrillation. So these are your dysrhythmias. I'm sure you will understand the dysrhythmias better when you look at the ECG next time. So good luck, and in the next session we will we will do the next unit, and until then, bye bye.